going, get going. All right, this is Tuesday's Bio 139 lab. We're going to touch on the urinalysis or renal system, and we'll kind of show some examples. I think we'll probably be getting out of here. And I think I have to see if we're going to be doing GI today. Is GI lab 9? Okay. All right, so we will go over, we'll probably go over GI at another point. There's not a lot to go over with GI, but I may send out an email with that since we'll be off next week. Okay, so let me get back to where I was. Sorry. All right, let's go over these findings. Now, the interesting thing, when we if we were to make a trip to the emergency room, chances are they will ask you to produce a urine specimen. This is almost like everybody gets a urine, because basically they're going to check your kidney function. They're going to check if you've are doped up on anything. Why they do check your kidney, because sometimes you need a CT scan, and if you need contrast, then they need to know whether your kidneys will be able to process the barium sulfate. I think what it is, it's barium something, because it's a very heavy molecule, and this will help, depending on how we function, how we measure kidney function, will help determine whether you were able to process this barium sulfate or not. If you cannot, this will smoke your kidneys completely, and then you'll be on dialysis. So it's kind of important. It's a big deal. We measure that in creatinine, and we measure that in glomerular filtration rate, or otherwise known as GFR. We will touch on those two topics later on down in the lab. So this graph here is something that we probably want to spend some time on, right? Now I'm going to go over each one of these and kind of explain the process behind it. And obviously, once again, if some of this is confusing or you don't exactly understand it completely, we do have Bio 139 spotlight sessions that I think students are proven very helpful. I know my 137 students have found it very helpful, at least the ones that pay attention to it. So do not forget about that resource. So, all right, so finding protein. So basically what this is, when you produce a urine specimen, basically it's going to come to the lab. All right, it's going to come to me. And what happens is, so I get all kinds of fun urine. I get nasty urine. I get clean urine. I get, diluted urine. I get very concentrated urine. You can usually tell. They usually have a certain odor to them. If there is some kind of pathological event, you can probably see my face scrunch up, because it just, you've been talking about it, brings back some fond memories. So when we have this cup of urine, there are these test strips, and there's none out right now. And they have these pads on them. It's like, think of it as like a test strip, a long cylindrical strip with different colored pads on each of these strips. And we will dip this reagent strip into the urine and pull it out. And then all of a sudden you start noticing that these pads turn different colors. And what that means is that each pad is indicative of what is in that urine. So for one pad, it's going to test for protein. If that pad turns a blue color or a purple color, will really depend on how much protein is in that urine. And protein's pretty normal. You're going to have some degree of protein in your urine. So to start off, if we were to look at this, and normally we would throw it through an analyzer, and the analyzer would read it, or if the analyzer is down, then we could read it ourselves. It's just more time consuming. So when we have protein in our urine, that is called proteinuria. It's in there. It's in quotations or parentheses there. And then, like I said, if you eat a lot of meat or chicken, you're going to have obviously protein in your body. And also if you're pregnant. Now what happens is that sometimes when pregnant women sometimes they have higher blood pressure, and more protein will get filtered out than normal, and that's okay. It just shows up in your urine. If you have a concentrated urine, chances are you're gonna have protein. If you are sick and you are producing antibodies are proteins. All right, it's just an amino acid chain. sometimes these antibodies will get filtered out into your urine, and vice versa. So pathological causes are basically when we cut with something called glomerular nephritis and hypertension. So glomerular nephritis, I've always struggled with that term. If I don't think about it, I can say glomerular nephritis. You know what it is. It's the glomerulus. That is basically the filtering mechanism of the nephron, okay? So think of that as the washing machine cycle of like a washing machine. It's on a spin cycle. So if it's on a spin cycle, it will spin at a high rate, and it'll push your metabolic waste through the filter and into the tubules, right, for collection purposes. It does. That's normal. This is when we get inflamed. Grace was asking in class, that's normal, what happens there. Now, when it becomes inflamed, this is the itis part. This is the nephritis part. These pores in the filter become a lot larger. And this is how larger things like protein, albumin, potential, if it's a diabetic state, sugars will get pushed through and make it into the tubules, proximal tubule. Okay. If you think about hypertension, if we have a lot of flow coming at a high rate into the nephron, chances are it's going to, under hydrostatic pressure, it's going to be pulled out of the blood and make it into the proximal tubule. Otherwise, well, Bowman's capsule, and then the proximal tubule. So is there any questions on that? Is there any review that we want to revisit on kidney function with the glomerulus? Make sure I have my speaker on. I do. Okay. All right. So we're okay there. Everybody's shaking their head. Okay. So proteins, normal. Urea is the breakdown of protein itself. All right. So now this kind of protein is protein that's probably in the muscles, or if you've had turkey, if you've had chicken, and it gets completely metabolized down. One of the waste products of protein is urea nitrogen, BUN. In this case, it's just urea. If it had a couple other molecules on it, then it would be urea nitrogen, otherwise known as BUN. So you're going to have a small dose of urea in your blood. Usually the liver will break this down a lot further. But basically the take-home message is that if you have a high amounts of urea, it would be impaired renal function somewhere along that line. You are not breaking it down. It's not metabolizing down further. Okay. And glucose. Glucose is the third one. Glucosuria is what happens when we have sugar in our urine. And this basically is more of a pathological state. If we are diabetic and we are taking in far too much sugar, eventually the sugar will overflow into our urine. This is kind of the body's way of getting rid of sugar at a high rate. If we can't absorb it into our muscles to make glycogen, or in our liver to produce glycogen, because it's some diabetic issue going on, then obviously the one way to excrete glucose is through the urine. So a non-pathological state would be a high sugar intake, and then obviously a pathological state would be some kind of diabetes mellitus issue. Brain injury or myocardial infarction. I'm not sure why those are in parentheses. Brain injury, I think we do have some glucose in our brain, but I could imagine that we would be causing glucosuria from a brain injury. Most of the time it's from diabetes mellitus. Okay, ketones. Ketones is probably another, let's stick with diabetes with ketones. So ketones, basically what happens, what ketones are is also another metabolitic byproduct of proteins. Okay, and it's found in the urine. It's called ketonuria. Um, yeah, It's, I think there's another pronunciation, but we're going to stick with that. And what happens is that when we are in a very low sugar state, in other words, we haven't had any sugar, we haven't eaten, and we are no longer able to break down glycogen to make new glucose through gluconeogenesis, which is just a metabolic term, then we will all of a sudden be in a low sugar state. And what happens is that when the body can no longer find sugar to metabolize to keep our blood glucose up, our blood sugar up, because our blood sugar needs to be anywhere between 80 to 100 it's on the tip of my tongue, deciliters per milliliter. Then what happens is that the body will start using protein breakdown as energy, okay, or fat. Actually, it's more fat than it is protein. So when we start utilizing fat, it's just kind of like the ketone diet. If everybody's ever heard that, you kind of get into the ketone diet where you eat a bunch of low carbs and then your body will start to oxidize fat. And the byproduct of fat is really ketone production. Now, we have to get rid of these ketones because they'll start affecting your blood pH, what we talked about last week. So it's it's something important. We want to excrete ketones as quick as possible. And when we have ketones found in our urine, mostly this would be from a low pH, because ketones will lower your pH. And this would be considered a diabetic acidotic state. We would test this if we think somebody is in ketoacidosis, diabetic ketoacidosis is the actual diagnosis term, then we would do what's called a beta hydroxybutyrate, which is just a fancy ketone that is indicative of somebody who is in a very low sugar state. And this would also show up in the urine. So if you want to correlate the ketone urine, and with low blood sugar with a high beta hydroxybutyrate, then you can almost diagnose and begin treatment on diabetic ketoacidosis. And that is a ICU. That's somebody who goes to the ICU. That's fairly serious. Anytime you have a pH imbalance in the blood, things can go bad quickly. And diabetic ketoacidosis is no exception. So ketones and low glucose or high glucose is a serious matter. Okay, now blood. Well, blood is, it depends on why blood's in there, okay? Blood can be in there from a yeast infection from males or females. It could be the lady cycle, which is common. A lot of times I will get urines with a lot of hematuria in it. And sometimes the diagnosis is bleeding while pregnant. And unfortunately, that is usually indicative of a miscarriage. And, we have to, depending on how far along the miscarriage is, they may have to undergo a D&C and kind of extract what's left of the embryo or fetus. I think it'd be first trimester, so it'd be more of an embryo based, but it's unfortunately hematuria, is common. Now I forgot to say, kidney stones are a big deal too. Yeah, you'll know if you have kidney stone. Despite the pain, my wife gets them. Luckily, knock on wood, she hasn't had one in a long time, but I think that's usually when you go to the ER and you say you're in pain, you think you have a stone, and they say, okay, go pee in a cup, and then your urine comes out, cherry red. They'll take you straight back because they know you're in pretty deep pain. You're losing a lot of blood just through the scraping of the kidney stones in the ureter. Okay, trauma, burns, anemia. It's basically you would have blood in urine if you have what's called an intravascular hemolytic event. So that's a big term. Hemolytic means that we're blowing up the red cells, and intravascular means that we are inside the vessel. Intravascular hemolytic event, and that just means that's probably what they mean by anemia at that point. Burns, I don't know where we're going with there. Trauma, obviously, if we have any kind of trauma or high impact injury, you're going to have blood loss, and that's one way of kind of filtering out the blood, other than the spleen, is through blood and through the urine. The intravascular hemolytic event is probably a transfusion reaction, and what they mean by that is that's when somebody has an underlying antibody in their blood, and a transfusion reaction. You know, obviously, if you remember the blood product or the blood lab, the very first week, we kind of talked about who can get blood, who cannot get blood, and what happens if we give the wrong blood. Well, if we give the wrong blood, you get a transfusion reaction, which means that your immune system starts attacking the foreign RBCs, red blood cells, from the blood product. And what happens? Well, those are red blood cells too. And if your immune system attacks them, then one way it does it, it kind of blows them up or neutralizes them, and then you will excrete them out through urine. Okay, I want to stop here and take a breath. I want to ask if anybody has any questions. I'm trying to do this on my spotlight sessions too, because I get in a rant. I get rolling. Okay. So we're good. Leukocytes. This is recorded, guys, so it'll go up on the YouTube channel, and feel free to tear into it. Okay. Leukocytes. Leukocytes, well, as you remember, it's white blood cells. So this, when you see, this is usually when there's one that comes up, you know, it's got a foul odor from the bacteria, and then you see it's like it's very thick. And that is like, I've seen them to where these people let these UTIs go so long. They let them go so long that they come to the ER, and there's literally like 2 layers of urine. There is white blood cells at the bottom, and then above that is the actual urine. And it is crazy, because then I have to like centrifuge the urine down to get all the whites out of it so I can even run it through the analyzer or get an actual result. So I guess pyuria is the term for leukocytes, and this is usually indicative of a serious UTI or any kind of UTI. Everybody has a little bit of whites in their blood. It just depends how much. All right, and that means, you know, if it's actual kidney infection, you know, let's say a UTI ends up in, you know, for women, UTIs can come from a lot of things. Sexual intercourse is one, and you usually get it from your male counterpart. So because they don't have a clean penis, so to speak. So if you were to go have sexual intercourse after going to the gym or something like that, or you have bacteria on your male part, and you have sexual intercourse, then you've pretty much introduced bacteria into the vaginal canal, and that is pretty much an incubator. Okay. I know, you know, when Megan, my wife, she had one, and I might've been the culprit, I don't know. She had I think it colonized her. I think it tracked up into her bladder, tracked up into her ureter, and then finally she was having so much pain to where it was pyelonephritis at that point. We'll talk about pyelonephritis. That's a more serious UTI that she had to get a shot, like an actual needle shot into her kidney to treat it. Because what happens is the bacteria tracks up. The ureter goes in the bladder, hangs out in the bladder, will track up into the ureter, and then if it gets really good, E. coli is one, Proteus is one. There's other ones. Klebsiella pneumonia isn't a big one that it'll track up into your ureter, and it'll colonize, and sometimes even your kidney. Sometimes you can get septic through UTIs, and that's a serious matter too. Males have this. My grandfather, I think, had Poppy in his late stages of life. He had that's what kind of landed him in the hospital. he had a UTI, I think, and that's usually what happens when most elderly men have larger prostates. You know, prostate cancer is something we have to watch. And when the bladder, and if the prostate is too large, then the bladder has a hard time relieving all the urine in the bladder. Okay. So then all of a sudden you get this urine retention in the bladder, and the bladder is supposed to be a sterile site. So all of a sudden, if you get a bunch of old urine in there that cannot drain all the way out because you have a higher prostate, chances are at one point it's going to become infected. Okay. And this is where in males, this is kind of where you can get yeast infections, or you can get a classic UTI, you know, and they can either give you pills, antibiotic pills, or you can get a shot in your bladder, a subpubic shot as they call it, or you can be as lucky as my wife and have to go get a shot into her kidney. You know, it's just a guided needle into the kidney to pretty much juice her up with pretty heavy antibiotics to just rid if you think about it, everything drains down, right? So if you were to inject the IV into the kidney, then the antibiotics will flush out the kidney, and then it'll go down through the ureter into the bladder and out the urethra. So that's one way of clearing a pyelonephritis or some kind of UTI event. Okay, I wore that one out. Glomerular nephritis, said it pretty well there. That is also, you know, anytime we have inflammation, you're going to have white cells. Okay, the itis is known for inflammation, and when we have inflammation, that is either caused by the immune system or it's being combated by the immune system. All right, nitrites. Nitrites are the metabolic byproduct of bacterial metabolism. So if your E. coli are hanging out and they are loving it and they've made it themselves at home, they're starting to metabolize. And when they metabolize, they make nitrites. We can pick this up on the pads, on the reagent pad. Now, I think gram-negative ones are the ones that produce nitrites. Gram-positives don't, but your chances are you're not going to find a gram-positive in that area. Gram-positives usually live on the skin surface. E. coli, that's gram-negative. Klebsiella, and you have to know this. I'm just kind of trying to help you connect the dots. Klebsiella, Proteus, E. coli. There's a few other ones that I'm missing, but those are the big ones that I've seen. They will all produce nitrites, and that's usually a UTI that has been there, that is festered, and you know, it's in growth phase. Okay, urobilinogen. Urobilinogen is a byproduct that is normally given off by the liver. Okay, urobilinogenuria. There you go. Very small amounts of this. We measure this in milliequivalents per milliliter. Usually it's 0.2 is the normal. And this is usually indicative of some kind of liver disease, cirrhosis, hepatitis. Those are the big ones, I think. Jaundice. Jaundice is and that's the next one, that's bilirubin. So this is all breakdowns of red blood cells. Urobilinogen is the breakdown of red blood cells. Red blood cells will live anywhere from 90 to 120 days. When they have reached the end of their line, the spleen, as they push through the spleen will clean them out. And then it kind of goes to the liver. And the liver will break down the hemoglobin, the heme molecule, the hemoglobin molecule, all the different parts of the red blood cell to make urobilinogen. If for some reason we have a high amount of urobilinogen, this kind of goes back to what we talked about with blood in the urine, hemolytic anemia. All right, we have some kind of transfusion event. Something has happened where it could be an autoimmune disease. We have a hemolytic anemia event, and basically it's just a large increase and breakdown of RBCs. And sometimes when your liver cannot catch up, it spills over into the urine, and we can pick that up. Bilirubin, or otherwise known as bilirubinuria. That is also, we're going to stick to the liver. This is going to be like a blockage. Okay. Another breakdown of right before you get to urobilinogen is bilirubin. Bilirubin basically is the prosthetic group and the heme group of the hemoglobin and the RBC. And when there is some kind of obstruction, either in the hepatic portal artery or any kind of issue going on with the liver, we are not able to conjugate the bilirubin. And if we conjugate it, that means it's water soluble and it goes right out into our urine, right? That's possible. If it's unconjugated, then it's not able to be released, and that's what kind of makes us turn yellow. Babies, usually these circumstances when people do not receive prenatal care, or they decide to have a at-home birth, which is fine. Sometimes they're not fine, and sometimes they go bad. And I remember we had one a year ago where somebody tried to do an at-home birth. The fetus remained in the vaginal canal for too long, suffocated, and was brain dead. And I think they ended up harvesting the organs to that poor baby. And, that baby was able to give life to another baby that was in need. But the point I'm trying to make is that if a baby were to survive, or they have this HDFN, if you remember it from the blood lab, hemolytic disease of the fetus, where mommy's blood and baby's blood is different, and baby's blood starts kind of getting attacked by the mom's immune system, this bilirubin this jaundice will start to show up. And that's kind of where you put these babies underneath a UV light. Well, what in the hell does a UV light do? UV light will help, when it hits the body, it will help conjugate the bilirubin for the baby to urinate it out. The whole process is to conjugate the bilirubin. And conjugate basically is just a biochemical term where it makes it more water soluble instead of versus fat soluble. And it's so large that the body has a hard time getting rid of it. And we don't want bilirubin levels to get too high in the body because it can cause brain damage. And they can get fairly high, but normally, like every morning, we will get from the NICU, we will get bilirubins, direct bilirubins on all of our babies. And depending on how that bilirubin result comes back depends on whether they're going to get some sunshine that day. And what I mean is UV light at a very low dose, by the way. It's not like we're just frying their skin off. But I'm not sure if it's UV light or if it's just a specific light. I may have to retract that. But I want to say my gut says it's UV light. And they will help conjugate this urine so they can, and that coupled with a saline bag, flush out the urine, flush out the kidneys, and then they can be healthy and get the heck out of the NICU when they're ready. Okay. pH, I kind of touched on this earlier. pH is, if we eat depending on what we eat, salads are more alkaline. All right. Salads are alkaline. If you were to test your urine after you went on a vegan diet, chances are you're going to have an 7.5, 8 pH of urine versus a high protein diet. Like I went and had Chick-fil-A. We went, for some reason, I was not craving it. She was. And I said, fine, we can do it. And it's good. It's just when you get to be my age, if you eat like crap, you feel like crap. I feel fine now at salad. But if I were to eat my normal spicy chicken sandwich, the chicken in there is obviously high protein. It would not be suspicious to have my urine pH all the way down from 6.5 to 6, sometimes even 5, especially for dehydrated. Because that's all like BUN, and there may be some ketones in there too, just dropping your urine pH so low. So a pathological state is going to be a diabetic ketoacidosis or starvation. And then obviously, if you have a vegetarian diet, you're going to have more of an alkalotic urine. Metabolic alkalosis would be. So how do we get metabolic alkalosis? Well, let's say you go out and you get your hands on some moonshine. I am speaking from experience when I was in college. And all of a sudden you're sitting there and you're watching the UK game, trying to mix in as much orange juice as you can so you can tolerate the moonshine. You end up vomiting up half of it, if not all of it. When you vomit, you are vomiting up all of your gastric liquids, juice, normal gastric juice. That's right around 2 or 3 of your pH. That also helps control your overall systemic blood pH. So all of a sudden, if you're in there, and this could be if you're sick too, I just used like an alcohol example, but if you're in there vomiting for whatever reason, chances are you're vomiting up a lot of your gastric fluid, your gastric juice, as we call it. And it takes time to make it back, but when you vomit up so much of that liquid in that holds a low pH, then all of a sudden you've pretty much induced yourself in an acute metabolic alkalosis. And you kind of feel funny. If everybody's ever vomited, your stomach's always queasy. You may feel a little different, and that is just your body dealing with the pH imbalance that they have. Now, if you were to go drink a bunch of orange juice, maybe that's a high acidity or something that has more acidity to introduce more acidity back into your stomach, that will likely help things. So that's kind of how we induce a metabolic alkalosis. If last week, remember we talked about hyperventilation? That would be considered respiratory alkalosis because we blew off all the CO2. CO2 introduces more acidity into our blood. So we're kind of hitting on the back end of pH. I'm sorry. You meant ventilation. Hyperventilation. If we're over here and I'm hyperventilating. Yeah. Well, if we retain so much CO2, then we are in an acidotic state. All right. Now, if I'm over here hyperventilating because I've had a panic attack, then I'm hyperventilating so much, I'm blowing off a lot more CO2 than what I should be. And when you blow off too much CO2, you can induce a alkalotic state in your blood because we don't have any CO2. And so if some of you guys who are interested in kind of connecting the dots of how the body will regulate, otherwise known as homeostasis, you'll find that blood pH is like priority number 1. All right. There's a reason between a blood pH range of 7.35 to 7.45. That is a very narrow range. And if you get beyond that range, these people who OD, these people who who are on heroin or something else and they OD, they stop breathing and all of a sudden their pH is like 7.1, 7.2, and then, they're in the woods. It's a serious matter. Organs begin shutting down when pH is off. Diabetic ketoacidosis is another one that's a big deal. So I just want to stress blood pH. Okay, specific gravity. Specific gravity is just a way of how we measure the concentration of your urine, okay? This is how we measure the concentration of your urine. So this is a mechanism that we use. It's also found on the reagent strip that will determine how your osmolality. If everybody remembers osmolality. Deionized water is the standard that we use to measure against. That's 1.000. So your specific gravity, if you have very dilute urine, that is 1.001, okay? If you have very concentrated urine because you haven't eaten or you're dehydrated, so your urine pretty much is all metabolic waste, then you're going to have, and when I say metabolic waste, I mean protein, I mean BUN, I mean red blood cells, anything. You're going to have a higher specific gravity, anywhere closer to 1.035. Why do we care? This test helps determine how good your kidneys are at concentrating your urine. People who are in dialysis, so I'm having a hard time finding my words today, who are in dialysis will have a much lower specific gravity because their kidneys are smoked. That's the reason why they're doing dialysis. Dialysis is there to do the kidney's job. If so, it's always nice to help see how well your kidneys can concentrate your urine if you are closer to the 1.035 region. Sometimes 1.055. You know, I've seen them pretty high too before, and that's not a knock on anything. That just means you have damn good kidneys, and that's a good thing. Okay, any questions?
I did. Metabolic acidosis. Would you say people that is it bulimia?
Bulimia, yeah, bulimia, yeah, bulimia, sure. Yeah, I didn't think about that. Any kind of psychological, Grace was saying that bulimia would be a good example of metabolic alkalosis. And anorexia would probably just be a dehydrated state also. Okay, any questions?
So the higher the number, you said the healthier your kidneys are?
For specific gravity, yes, I think you can say that. If it needs to concentrate, it's kind of like a stress test. They're not always going to be like 1.035, but if you were out in the desert and you haven't had anything to drink and your body needs to kick out all the metabolic waste and retain as much water, then you can really, put your kidneys under some exercise.
Thank you.
No problem. All right. All right. So this is kind of an example of what we're going to go through here. Of how we can measure extracellular fluid and osmolarity. So this is just asking you to try to eat some kind of food, and it's going to want you to list what you did. So I'm trying to make an example here. All right, let's use my Chick-fil-A. Let's use fast food, Sodium Central. I had a sweet tea with my spicy chicken sandwich with my fry. I guess it's not that healthy. No, I had a salad, but normally I'd get my spicy chicken sandwich. That's sodium. It's a lot of sodium, processed foods, not the best that you want to eat. So we're going to have a high sodium diet. We're going to have a high protein urine. So if my body already has a lot of sodium, it's going to kick out some sodium into my urine. If chances are some of this protein, or at least the fried breading of the chicken sandwich, that will be like some lipids. They'll get retained, but they won't make it into the urine. But maybe some of the processed molecules will be. And of course, my sweet tea. Let's say if I had like an ultra sweet tea and I drank a lot of it, then sometimes that glucose will overflow into my urine to kind of kick it out. Okay. So what happens there? Well, you may find that because I did that my body is going to kind of become in almost like a dehydrated state. Because if you remember, sodium, what follows sodium? Water. Water will follow sodium. So if we kick a lot of sodium out, chances are water is going to go out with it, and we may want to retain water. So it would not be a surprise to me that my urine is a little darker. You can always tell how hydrated you are by looking at your urine. If your urine's very dark or yellow, or even yellow at some point, you have some degree of dehydration. If it's more clear, and obviously if it's more dehydrated, you're going to have a higher specific gravity. Chances are if it's more yellow, that's the urobilinogen in your urine that's causing that issue. Same with, there's a reason why excrement or feces is brown, because that is from your urobilinogen. That's the color it gives off. The reason why your red blood cells are red is because we have iron in our red blood cells. Iron's the one that gives it this color. And you mix it with oxygen, that's how you get like a bright red versus a dark red, arteries versus veins, respectively. Fun fact. Okay, so trying to see what happens. So we're gonna have all of a sudden very concentrated urine. If I were to sit there and drink a gallon of water, then I'm going to dilute everything out. And all of a sudden my urine is going to be less yellow, probably more clear, and it's going to have a lower specific gravity because all we are is just filtering water through our body. Okay, so this would be known as, I want to skip some things because I want to go down to the graph. On page 72, that's something that we would do at home. Chances are, if you guys do this, all your urinalysis is going to be negative. It just is. You may have a little bit of protein, you may have a little bit of blood, you may have a little bit of whites. You won't have any nitrites, and your pH will probably be around 6.5. Chances are. So let's skip over 72. Now this urine flow, we're not going to do this today. This chart that says volume and specific gravity and your chloride content in urine flow, we're gonna skip over that. I want to see if there's a way I can teach that. I need to look at the quiz and the exam to see if we're actually going to do that, because it's very complicated to teach over the computer. So we will revisit. I will revisit the bottom of 72 and kind of explain what's going on. But I probably could help explain the urine flow rate, specific gravity, and urine excretion. Okay, we probably could do that. Let's do that. Sorry, I'm looking. I'm probably going to talk about 73, page 73. I'm going to look over the bottom of 72. So I will get back to you on page 72, but I want to talk about page 73. Okay. Page 73, we're going to talk about urine flow rate, specific gravity, and we're going to follow chloride. Of all electrolytes, we're going to follow chloride. Chloride is Cl negative. All right. What's positive? Chloride's an anion. There's other electrolytes that are cations. So one that comes to mind is sodium, NaCl, right? There's a reason why we always hear about NaCl, otherwise known as just normal table salt, is chloride loves to hook on to sodium, all right? So wherever sodium goes, chloride goes. Wherever sodium goes, water goes. Okay, so UFR basically is the filtration rate. So this is how much, this is measured, the glomerulus will measure the filtration rate. So urine filtration rate, UFR. It could be anywhere from 60 milliliters per minute all the way down to 30 milliliters per minute or higher, 120. Really will help filter. It'll help figure out how good your kidneys are at filtering blood, the glomerulus. So I'm going to just introduce these terms. Specific gravity, we've kind of talked about. Chloride content, we will reiterate it when we go there. UE, what is UE? Is that urine flow rate? I don't know what UE is. No? Sorry guys, let me Google what UE is real quick.
Is it the urinary excretion of chloride?
Yeah, sounds right. I mean, it sounds kind of redundant, honestly, but did we look that up?
It's in the top of the page where it says explain.
Oh, it does. Okay. So we will try, I think that'll be kind of similar to excretion rate. So that's going to follow water and sodium. Okay, thank you for that. All right, let me pull up and go back down. So water, if something's hypotonic, do you guys remember what hypotonic is? Isotonic and hypo versus hypertonic. A hypotonic is going to be more water-based urine, okay? Not very concentrated. All right. Your urinary flow rate, UFR, is going to be higher. I think we're just going to do arrows at this point. Specific gravity would be lower for hypotonic solution. Your chloride would be lower. Your urinary excretion of chloride, it would also be lower. And then your ADH, antidiuretic hormone, if you guys recall, that is pretty much is the hormone that will place water aquaporins or water channels in the collecting tubule of the nephron to retain water. Well, we want to, if we are at a hypotonic state, then we are not going to have a lot of ADH concentration. We're going to have low ADH, okay? Because that way, the reason why our urine's so dilute is because we have so much water on board, and there's no reason to retain more water. At this point, we'll probably have too much water, and we're trying to kick it off. Okay. Salt water. Okay, isotonic solution. So salt water, when I think of salt, I think of NaCl. So we'll probably talk about a little bit about NaCl. There's really no change here. So salt water isotonic, that's like saline, okay? That's like physiological saline, something that you would get in the ER in a hospital setting if you're dehydrated. Everybody kind of gets it. It just kind of helps get your body back to homeostasis. UFR would be, you know, anywhere from 60 milliliters per minute to 120 milliliters per minute. There's really no arrow to assign here, okay? It's just normal rate. What is the normal rate? 60 milliliters per minute all the way up to 120 mils per minute. Specific gravity. That is kind of the range that we talked about earlier, right? So normal water is 1.00 all the way up to 1.0035. That's specific gravity. Chloride content. Chloride content in our body is probably right around 120 deciliters per milliliter, okay? That's the same thing as chloride, or sodium. Sodium is Na+, chloride's NaCl-. They're going to attract to each other. All right, UE, I think, who was it? Was that you, Liz, that said that? Urinary excretion of chloride. That, I don't know that. I think you're going to be excreting as much chloride as you take in, okay? This is normal flow. I don't know the milligrams per minute there on that, and chances are you'll never use that. So I think no change really in the UE per chloride. ADH, normal. It's not going to be high. It's not going to be low. Okay. Now, no intake. So we're out in the desert. We haven't taken any water in. We still are metabolizing. Okay. So we still are making a metabolic byproduct. Our urinary filtration rate is going to be a lot lower. Okay, it could be pretty closer to 60 mils per minute. That's kind of like the basal level of GFR, or UFR in this case. Specific gravity, well, if we're not taking any water in, we certainly are concentrating our urine, right? So we're going to have a higher than normal, we're going to have a higher range of specific gravity. Anywhere from 1.002, maybe all the way up to 1.005. And guys, I just realized that I'm putting too many zeros in that specific gravity. It's 1.035. I told you 00, it's just 10. If it's in double digits, like it'd be 1.005 all the way up to 1.035. So just want to clarify that, sorry. All right. Oh, your hypertonic would probably be closer to 1.035 or 1.05. That'd be like at the higher concentration of your urine. I put too many zeros in there, and that's wrong. Chloride content. Okay. Well, our chloride content in our urine is going to be a lot lower. Okay. We are going to retain a lot of sodium, because sometimes if we retain sodium, we retain water. In this case, if we're out in the desert and we don't have any water, we are going to want to retain as much water as possible. Therefore, we're going to want to retain as much chloride as possible. and subsequently sodium. Okay. Our urine excretion of chloride, UECl, that's going to be low. Okay. And then our ADH is going to be high, because you think about it, whatever water does get into that urine, and some water does get into the proximal tubule, make its way up through the distal convoluted tubule into the collecting duct. If the water is still there in the collecting duct, that ADH is going to stick aquaporins, and it's going to pull out as much water and reintroduce it into our circulation as possible. I think the vasa recta capillaries that will kind of corkscrew around the tubules, that is what first gets the water out of the kidneys or collecting tubules. So do we have any questions on that? Okay. Hopefully you guys just holler at me if you have anything. All right, let's go into kidney. Looks like we have pictures here, so I don't have to take any pictures. So this is the renal cortex on the left. And then I think number 4 is the renal tubules. You know, it looks like a cross-section tissue right there, pretty much cutting it right on top and then looking down into it. I don't think we have a whole nephron. That'd be kind of cool if we had a nephron. So just revisit these. There's really nothing for me that I could go over that's interesting. The renal corpuscle. I don't know. I had it yesterday. Renal corpuscle. That is just the glomerulus with the Bowman's capsule. That is not with the different tubules. That's going to bother me. I want to say that all the way home. So Bowman's capsule is number 2. You can kind of recognize that number 1, the renal corpuscle, is the whole thing. That is including the glomerulus and the Bowman's capsule. Okay. And number 4 is just a renal tubule. Nothing to add there. Okay. So we have pig anatomy on 75. I may have to take pictures of that. Usually Raymond lets me know what you all need. And I think, Raymond, you're going to need some more pictures from me. So I will send that out before I leave. You're going to need, well, no, you do have, no, you don't have the answers. Okay. All right. I will get you the urinary model key and I will send that out. And then 78 is just some things we need to go over with anatomy wise. All right. So here's your cartoon on 79. That is, you have the medullary lining that's closer to the bottom on the left on the nephron, you know, versus the more peripheral, which is on the outer portions of the kidney. I don't think there's anything much I want to add there. And I think that's all we're going to do today. Okay. Yeah, that's all we're going to do. All right. That's a lot of material today, a lot of information. Do we have any questions? Okay. All right. So I will get you these emails. I'll get you these pictures for the urinary pig and the cartoon. I'm sure if you guys have any questions, you'll reach out. And we are on spring break next week. So enjoy that very probably much needed break. And we will come back and do GI and we will review. We'll probably do a review session either from I'll probably be doing it from the home office. We'll just have to see there. I'm not sure if there's a reason to come in and we'll go from there. So you guys enjoy the rest of your week and good luck on your exams. Oh, I just saw your all's chats. Sorry. Yeah, sure, Carla. Okay, that's been a half hour ago. Yeah, and Clarissa, your VUR. What's the VUR part?
It's reflux.
Oh, okay. Okay. Yeah, well, I'm sure that'll do it. Okay, so quiz. You want to go over last week's quiz, Carla, or this week's? This week's, I think, is pretty straightforward. Let me see what I have here.